even the caregivers will be very much frightened with this symptom. So it is important for us to understand how to manage breathlessness and other respiratory symptoms. So we have Dr. Rajam Iyer today with us to enlighten us on the respiratory symptoms. She's basically a pulmonologist, but doing palliative care for last few years. She's working in both Bhatia Hospital and PD Hinduja Hospital in Mumbai. She has done her diploma in palliative medicine from Cardiff University, and she has actually has keen interest to integrate palliative care into pulmonology, and she has membership in various organizations, and she has won her Govind Award. So we shall wait till Dr. Rajam joins us. So in the meantime, if any of you have anything to tell us about the sessions, we can discuss that.
Hello, sir.
Yes.
Sir, do we have any discussion session planned for the assignments scheduled, sir? At the end of the course, maybe?
I didn't get you.
Sir, for the assignments scheduled, is there any discussion session to be held, or like any key answers or discussions to be planned?
Srithya, what is the usual?
Sir, I have already put up this request to the core committee, but I'm yet to get any reward from them. The one concern we're facing is that our program doesn't end here. Our FCPM program doesn't end here. So suppose we disclose all the MCQ answers to such an audience, maybe our quality of the program might get affected in coming batches. So that is one concern which they were sharing. But then we do definitely have an option if any of the participant is facing any difficulty in one question, maybe they can definitely discuss it with Dr. Sunil Kumar over here.
Okay, thank you, ma'am.
So I just got a message from Dr. Rajam that her device is having some technical glitches and that is causing the delay. So we'll be waiting for her, and till the time she joins in, just an update from the coordinator's desk that we will be having a short break of 1 week after this session. Our next session will be on next Monday only, on 13th. We will not be having sessions on coming Wednesday and Friday, just for the information of everybody.
So this is in account of IFPC conference, which is happening in Bangalore. I hope some of you will be attending that. We will see that.
Yes, Parliamentary team is definitely going to be part of the conference, and we do look forward to see some of you there in person.
Ma'am, then the FCPM, the phase 1 will extend beyond Feb 28.
No. This was already accounted for.
Okay.
The break was already accounted for, and that is how we had scheduled.
Okay. Thank you.
So when 27th February, isn't it?
Yes, sir.
FCPM ends.
Yes, sir.
Sripriya, will you be notifying us or sending all the participants any further conference invites? Is there any database that you send it? Because I don't know anything about this IPC. Anyway, it's too late to attend.
Definitely. Sir, over to you, sir.
Yeah, Dr. Rajam has joined.
Sorry about this, but can you share my PPT?
Sabri,
Sure, ma'am. If you have
Because my
mailed us,
computer is playing up and I've logged in from the phone, and I really don't want to delay any further. Apologies for this delay in the first place.
your introduction is already over.
For coming, and sorry for this delay in starting today's session. I hate to be late, but today everything seemed to go haywire for me. But thank you for joining after a full day's work on a Monday evening. I really appreciate that. And without waste of time, I know quite a few of you have already got familiar to this presentation also maybe, and just wanted to tell you that the reason for having this kind of session is also to familiarize all of you the need for palliative care, especially in non-cancer conditions, because all of you, as you know, historically, palliative care was started for patients with advanced cancers, and therefore somewhere down the line it has always been transformed and translated that only patients with cancers who are dying need palliative care. And we, along with the help of Pallium India, and all of you, need to change that myth. So can we have the next slide, please? So this actually shows why in India we really need to focus on palliative care for non-cancer conditions also. And from this table, you will realize that a lot of Indians, close to 50% of Indians, suffer from non-communicable diseases, that is lifestyle diseases. And as you all know that these lifestyle diseases are very difficult to cure, and they are only controlled, and these patients could have a roller coaster ride of repeated hospital admissions or seeking medical attention. And therefore it is important that these patients, we address these patients who have high symptom burden for a prolonged period of time. So it's very important for us to realize that conditions like diabetes, hypertension, cardiac disease, COPD, interstitial lung disease, chronic renal disease, chronic liver cirrhosis, these are conditions which these patients suffer for 5-10 years, dementia, and it can have very high symptom burden, and therefore lead poor quality life. So even if they are not even if they are not like cancer where you can predict their survival, etc., the point is the patients and the caregivers go through a lot of suffering, just as what we in palliative care want to alleviate. So it's very important for us to realize that yes, in India we do have 1 million new cancer patients every year, and yes, they do require palliative care, but we have a whole lot of Indians who are affected by non-communicable diseases who also need the help of palliative care. Next slide. So this is just because the focus is on respiratory medicine. This thing is to tell you how all the incidences of COPD, interstitial lung disease, as well as unfortunately the infectious disease of tuberculosis also is difficult to treat sometimes when it becomes XDR TB or MDR TB or total drug resistant tuberculosis, and the incidence of all these conditions. So in India, we do have about 18%. So basically the point is the 1/3 of the global burden of respiratory conditions is borne by Indians. So because of our large population, a large amount of, and the culturally, because of domestic pollution, cigarette smoking, air pollution, and so many other contributing factors, and the poor awareness of protective devices, etc., the incidence of COPD, the incidence and awareness of interstitial lung disease is also on the rise. So the need for palliative care in respiratory medicine is only growing. Next slide. And this is a slide that I think most of you will be familiar with, which is the way and the trajectories in which people die in the world. The focus for today's talk is graph C, where these patients start with a quality of life on diagnosis of COPD or diagnosis of interstitial lung disease. And as you can see in graph C, and as I mentioned earlier, the duration of symptoms is prolonged, the high symptom burden, and the fact that every acute admission leads them to a poorer quality of life. And what we find it very difficult is to convince patients with non-cancer chronic conditions to avail palliative care, because it is unpredictable. So suddenly the patient from the ICU can actually bounce back and lead a decent quality life, which is enough for the caretakers. Also, the diagnosis of COPD or the diagnosis of interstitial lung disease, unfortunately, is not perceived as life-limiting. It is also the fault of the pulmonologist, because they give them treatment and patients think that the treatment is actually for cure and not for control. So it's very important to honestly give the patient the realistic picture, because it is our onus. Since we have seen more patients of COPD and interstitial lung disease, the onus lies on the treating pulmonologist, treating nephrologist, treating gastroenterologist, cardiologist, and neurologist to give what is the foresee and foretell the picture of a trajectory like a chronic, incurable, progressive conditions. So it's very important to let them know that the treatment you're giving is only to control and not to cure the COPD, because COPD, interstitial lung, etc. are incurable conditions. Next slide. And if there's any question, if there's anything on the chat, Sunil, and please, please highlight it. We can stop and we can start. Idea is not to finish. I know I've started late. Idea is to understand and get the gist and engage in interesting interaction so that I can learn from you and vice versa. So if you, there's this beautiful paper which was published in this, I think it's a Spanish, Italian paper, where they have compared the trajectory of a chronic illness to that of falling off the skyscraper. So this is where the onus of a treating doctor comes into place, where as the patient's condition is deteriorating, it is our responsibility to foresee and foretell and prepare our patients and families for what is to come in the future. It gives them time to plan, and it gives them time to actually tell you and make a decision, process and analyze what they're going through, and tell them what they would like to do, what they would not like to do for them in an emergency. Because the manner in which you fall is directly proportional to the way you land. Typically, we wait till the patient becomes so critical, and just when he's about to crash is when we tell the family that really now the patient is very critical. If we changed that situation and had these difficult dialogues and started good, sensitive, timely communication, patient and the family is prepared for an eventuality. If it doesn't come, it's fine. But when it comes, they know and they can relate to the fact that, yes, the doctor had mentioned that this will happen. So it's important to time our conversation. It is important to realize the skills of communication, because it's not only what you say, but when and how also makes a big difference. Next slide. Therefore, our main aim in palliative care in any chronic illness, let's not label it as, let's not label it as only cancer or only dementia or only respiratory, any chronic condition, even if it has a cure, the patient and the caregivers go through a lot of difficulty during that journey. So our aim as palliative care physician is to integrate it early with every specialty so that the journey becomes bearable. And as the curative options become less, we intervene, and it's a smooth transition for patients and caregivers from curative to palliative. Typically, even after 5-6 years, and Sunil will vouch that even after 25 years of Pallium India, still patients get referred very late. And imagine suddenly the patient is told by the treating doctor that I cannot do anything. Now this doctor will look after you. It's almost like abandoning your patient of 5-10 years. So it's important to integrate palliative care physician as your team member so that you can transition it peacefully, saying, we have all been looking after you, but now this particular doctor is going to be more important because we have really run out of curative options. There is a lot we can do to comfort the patient, but it's important to be there for your patients in the hour of need. Although we cannot change the outcome, we still can make the journey much better for the patient and the caregivers, support them through this difficult journey. And the beauty of palliative care doesn't end with the death of the patient. We continue to inquire about the wellness and mental, physical, emotional of the caregivers after they have lost their loved one, which is so very important, because some of you who have lost a loved one will realize the importance of what you go through during that phase, and having a medical team to support you can really be beneficial. So next slide, please. So then, the next question that very often my colleagues ask me, is, once you talk about palliative care, patients feel hopeless, patients feel they're going to die. So this important question of when you should actually be sending your patients. Earlier is better, but there's another research that was done in England with the surprise question. I'm sure most of you have read about this or have heard about this, which is that in your mind, when you're sitting in the OPD and seeing this patient, think to yourself, will you be surprised if the patient is not alive in the next 1 year? You as a practitioner, clinician, are aware of the signs of how the patient is going downhill. And if you think that this patient is not going to be alive the next 1 year or see the next calendar year, that is the time to start proactive palliative care. Talking about death and dying takes time, and we need that time for the patients to process, to analyze, to understand where they're coming from. And this is important for physicians to realize that this 1 year is used to establish the rapport, give the patient the time to think, give the family the time to understand, and it also gives you the time to help the patient make decisions in what he needs to be done in an emergency. Because you and me both will agree that learning to swim in a calm sea is way more better than in a storm. In an emergency, each one of us, you, me, also end up taking wrong decisions. So we need people to have these difficult conversations, and we need time for that. Next slide, please. And the gold standard framework, as well as the Blue Maple document from Manipal, have listed indications for referrals in each chronic condition. It is an extremely important document which Pallium India can share with you. Some of you already might have it. And it's very, very simple. It actually makes it very simple to give you the criteria of when you should refer these patients to palliative care. For example, in COPD, it is any of the two: elderly above the age of 75, recurrent hospital admissions, that is 3 in the past year, MRC grade 4 or 5, where the patient is breathless at rest and on 24-hour oxygen, or falling lung function parameters, or if the patient fulfills a form of pulmonary hypertension, or the patient has been to ICU, or has severe uncontrolled comorbidities. So if the patient meets the criteria of any of these two, this patient does not have a great prognosis. This probability of this patient to not live beyond a year is high, and therefore that should be the point where you actually refer the patient to palliative care. Any questions, anything on the chat? Please let me know. There is something on the chat, I think.
No.
I have one query.
Yes.
Did you mention the age, including for the referrals?
See,
I didn't
elderly
hear.
is higher probability. So 75 plus is what we consider as the age, So especially in respiratory diseases, age above 75 or one of these criteria, your antenna should raise and say, this is not looking good. And I think it's time to involve others, because we will prevent unnecessary, aggressive, futile medical interventions in a lung that is already so compromised.
Okay, thank you.
Yeah.
Thank you, ma'am. Thank you.
Okay, the next slide is the two documents I was talking about, which Pallium can share with you, or you can also download it from the net, which gives you in each condition. So it's an interesting document where they say COPD, dementia, motor neuron disease, CKD, all chronic illnesses. They have specific criteria because the suffering involved in any chronic illness is really high. And if you've looked after somebody with any chronic illness like this, you know the amount of caregiver burnout and the amount of life, the way the life of the caregiver also is limited, socially, emotionally, physically, in all sense. So it's important to support both the patient and the caregiver. So next slide. So this is actually to highlight the fact that even today, in a 2010 So that's the 20th, 21st century article published in the West, shows that people with non-cancer hardly get palliative care. And it is very sad to see that those, next slide, patients with non-cancer palliative care, I mean, those at the end of life have very few of their distressing symptoms documented, therefore very few of their symptoms treated. A large majority of them underwent CPR, which is so sad, against dignity and respect, and medications to comfort the patients were very less, which shows that the quality of death of patients with non-cancer diseases is very poor, as reflected in India by the quality of death index. Yes, we have improved from 67 but to 59, but there is a long way to go to be proud and say that our patients are dying in peace and our patients are dying in with comfort and dignity and in the manner that they want to. Everybody's life, they should have the right to the exit option also, especially if there is a chronic, incurable, progressive illness. Continuing to make them suffer at end of life is a big torture, which unfortunately happens in our country very often. Next slide. We have there also have interesting articles to show you that even those patients who have been admitted in ICU, hospitalized, still what we don't realize as acute clinicians is we see patients only during acute admissions. We don't see these patients once they go home. And the statistics of having admitted patients with acute exacerbation of COPD is that only 25% of them live till the next 6 months. The rest, almost 50%, get readmitted. So we don't realize how poor their quality of life is. And in India, unfortunately, this Sada Yushman Bhava focus on the quantity of life is so ingrained that some patients actually tell you, it's okay if my father just sits in one place as far as he's alive. But the point is, nobody asks the father what he wants. So the question of choice, which is something which only health care professionals somehow don't offer. And patients also very often says, Doctor Saab, aapko jo theek lage, aap karna. Aapko jo karna hai, wo karna. So in very often doctors say, in my experience, he should go on the ventilator. In my experience, this should be done, which is not right, because the person who's enduring it might be a frail 90-year-old. You know, for example, every time I think of it, today is the first death anniversary of Lata Mangeshkar. Do you all remember how she died? She had COVID. She was 92. She was in ICU for 28 days. And the reason she became the Nightingale of India was intubated twice. The vocal cord was intubated twice. Was she asked how she wanted to die? Is this how any 92-year-old wants to die? So there are so many questions. So this thing brings me to the question that if Lata Mangeshkar didn't have a choice in this country, imagine what will happen to you and me. It is very important to think about it, that money, power dictates. And somewhere we feel the more we do, the more love we have for this person. It is not so. You can also show love by letting go, giving the person the dignity and comfort and asking him the choice. So she also had very bad COVID pneumonia. And by the time she died, we had enough data to suggest that elderly with COVID pneumonia, with refractory hypoxia, do not make it. And still we pushed and pushed and pushed her to be kept alive, not to live life. Yeah.
So ma'am, I would wish to interrupt here.
Yes.
Could I ask a question, please?
Please.
So I just
Can you introduce yourself, because I am on a small frame.
Yeah, I am. Sorry. I am Dr. Priya Ramakrishnan.
Yes.
I am an anesthesiologist from Dehradun. So you mentioned this case of Lata Mangeshkar, but maybe she had not left an AMD. So what do we do when a patient gets ill?
No. So definitely she is not left an AMD, because in India, that is also not a norm. Correct. So the point, very good point raised, Priya, and I can see you nicely snug in some warm clothes in Dehradun. I'm envious of you. But what I'm saying is, this is another thing that we need to encourage right from our medical schools. First is ask people choices. What do they want to do? We don't even do that. Next,
Mm.
when they actually tell you the choices, document it. That can become your medical directive. Document it. IAPC website has a living will draft. Ask the patient to fill it. Tell the patient to show it to his local GP. Tell the patient to show the people who are going to rush him to hospital. And we can make a full full foolproof document. So what we do here in Bombay is, once we have the wishes of the patient, we try and leave that thought of the patient and the family for some time, because definitely the sons and daughters say, "Aise kaise, how can I not do anything?"
Yeah.
So there is lots we have to tell them that they can do. For example, when the patient is breathless, for which I will come. Second thing, we involve the GP. We tell the GP this is the patient's wishes. Third thing, we tell the pulmonologist under whom he will get admitted that these are the patient's wishes. Fourth thing, we educate the family that once they arrive in casualty, to be very specific and say, I do not want ICU, I do not want intubation, I do not want CPR. I want you to give me comfort care in the ward with maximum ward care. So our patients sign that document because it is a medical legal thing that the casualty medical officer asked for ICU admission, but the family and the relatives signed and say no ICU admission, no intubation, no CPR. Patient wants to be in the ward. So such patients, code blue is also not called out for.
Okay.
And similarly, if the patient says, I don't want to go to hospital only, then the GP is involved. The GP family doctor is trained in giving all the medications for distressing symptoms. And the GP then, if the family can afford it, has a nurse to administer those medicines, or the GP goes and gives those medications under the supervision of a palliative care physician. And I just get a message saying, so and so died peacefully at home.
Okay.
The point is conversations and choice. These are the two important C's that we do not teach our medical doctors. Very often they say, I think you should do this, but you're not the one taking AKT. You're not the one enduring the intubation. You're not the one taking the chemo. So ask. It's very, I always tell this also, that it takes 2 minutes to intubate a patient. You are an anesthetist, you might even take lesser. But it takes 2 hours to explain not to intubate the patient.
I
And
agree
time is
totally.
money in private practice. The more you do, the more you see, the more you get. But the suffering, the fact of, I always feel we are healthcare professionals and we've forgotten how to care. We are just mechanically doing one thing after the other. So we should at least try. Yes, it is time consuming, but if it is done correctly, when it is done, when everybody is comfortable, the situation is calm, the penny just does drop. There are people who see the futility of ICU casualty, ICU intubation, arterial line dialysis. There are patients who, even in ICU, say, I don't want all this, just let me go. If you're telling me it's a futile condition, doctor. But we keep them comfortable with the morphine, midazolam drip, and let them transition in sleep.
Thank you so much. Thank you so much.
Yeah. Radha Ganeshan, you're correct. Many hospitals survive on ICU admissions, and the joke is that corporate hospitals, the rich cannot come out, the poor cannot go in. So this is the mantra, but that's exactly what I'm trying to say, that if a 40-year-old is poor and cannot be put on the ventilator, he is denied because of economic reasons, while a 90-year-old dementia gets a ventilator because he can afford to pay the bills, which it is not the justice in medical ethics, right? It's very important to give choice, which is autonomy. Do what is in the best interest of the patient, not cause harm. And we cannot treat a 19-year-old and a 90-year-old in the same way. I think that is criminal. So these are my thoughts. We are allowed to debate. And I'm sure when it comes to ground level, things are different. But at least we need to try. We need to communicate and we need to offer patients choices. Patients are not used to getting choices in this country also. So which is also needs to change. Next slide. So this is another follow-up of the same thing, that if you see follow-up patients 5 years after their intubation, close to 70 to 80% of patients are dead. So are we just prolonging poor quality life, or are we returning them to good quality life? That is what the question is. In the process, those patients who can return to good quality life, we are denying them a chance by occupying beds in the ICU of those patients who probably will never return to good quality life. These are difficult decisions, but at least we need to explain to the patients so that they can make a choice. Next slide. So when we come to respiratory system, I'm not going to talk about this in detail. All I want to highlight is the importance of blood gas and importance of lung function test, because the rest is almost always commonly done. Lung function test is very underutilized, and it really can give you a good idea of the general health of the patient, whether the patient has got good FEV1, good vital capacity, and that actually gives you the probability of his survival. And blood gas is also important because it deciphers between type 1 and type 2 respiratory failure. Next question, next slide. Again, this is something which is not taught to us when we do any medical training. When we do medical training, we are taught to ask onset, duration, progress, are you better with the medication, cough, breathlessness, etc., etc. How their particular symptom affects their quality of life is something we never realize unless you have experienced this firsthand at home when you have a patient with ILD or COPD. The amount of distress, the amount of dependence, and the poor quality of life that these patients have. So they're not only anxious, scared, they're worried, they hate to be dependent, they're frustrated, so many things. And most of our respiratory patients die a social death before a physical one. They cannot go out, their age group people cannot come and visit them. So overall, they're very depressed, or they can be very frustrated or angry. And these are the questions, these are the situations we need to actually elicit from the patients. And how do we do that? So next question. That this is in the history taking. We need to improve our history taking. Instead of us, we almost always, are you better or are you worse? We need to ask them questions like, how does your breathlessness, how has it changed your life? Or what is it that you have stopped doing because of your breathlessness? And that is what opens all the Pandora's box. When patients will start saying, I cannot go to the toilet alone, I have to depend on somebody for changing, I cannot even wash myself, or I cannot talk a full sentence on the phone, or I cannot even play with my grandchild, eat with my family. So these things and these situations are the ones that directly contribute to the patient's quality of life. And that's what we are here to address. Next question. So that this brings us to the breathing, thinking, functioning model, which again, a lot of you would have seen. So our patients who are breathless because of the underlying pathophysiology of COPD, ILD, primary pulmonary hypertension, etc. These patients, because they are bed-bound, house-bound, room-bound, stuck to oxygen, the only thing that is active is their mind. I am wasting so much of my son's money, or my son is not able to go out because I am so sick, or I am so dependent. So they constantly has an overactive mind, which actually makes them anxious, scared, frustrated, various issues in the psychosocial factor. And because of this, they feel that now if I walk a little bit, I get more breathless. So because they're breathless and they're anxious, they are already very breathless, and they say best is to stay put in one place. And what happens with staying put in one place is they lose their muscles, they get deconditioned. And our patients get stuck in this vicious cycle of breathing, thinking, functioning model. And palliative care does everything to break this cycle. Pulmonologists treat the breathing, psychologists treat the mind and the anxiety, and the physiotherapists deal with the conditioning of the patient, make him at least be able to do simple activities of daily living with less effort. And the palliative care physician is the one who oversees all this, is a constant support for all this as a team member. And therefore it helps because it's a multidisciplinary team. Patients are intimidated to ask doctors silly questions. These people, the social workers, the nurses, the volunteers, the psychologists, the physiotherapists help in bringing out difficult situations that the patient is going through. Next slide, please. So what we are going to talk about today is what is commonly seen in patients with advanced COPD and ILD, and also in certain patients of congestive cardiac failure. These are patients who are what we suffer from chronic breathlessness syndrome, a term coined by Professor Miriam Johnson and Dr. David Currow, where patients who are breathless despite optimum medical treatment. And that breathlessness, which affects the psychosocial economic life of the patient, is chronic breathlessness syndrome. Whether it's for 1 day, 1 hour, 1 year, 1 month, is irrespective. But the minute the patient is chronically breathless, even on maximum medical treatment, and his quality of life is severely affected, these are the patients who need help. And these are the patients who go unrecognized. They are invisible, and therefore it's very poorly identified and treated. Next. And what do we do in chronic breathlessness syndrome? There's a whole lot of things. So when relatives say, oh, how can I watch my loved one suffer? I will rush him to hospital. These are the non-pharmacological things we can educate our patients' caregivers by saying, first, position the patient, keep him in a well-ventilated room, keep him next to a window, let him wear loose clothes, teach him some deep relaxation techniques. You can also teach him to music therapy, distraction with pets, and a handheld battery-operated fan works wonders to reduce the sensation of breathless when it is blown on the face. So very, very important that patients, relatives can be taught all this, because this is the seva bhav, that they are doing something for their patient. Everything doesn't need to be casualty, ambulance, rush to hospital. These are the things they can do before we start the pharmacological treatment. And the pharmacological treatment, which we explain to the family and the family physician, is next. You know about everything that can be used in airway diseases and lung diseases. I'm not touching about it, but the most important thing we need to talk about is morphine. Very often, pulmonologists, my colleagues, actually fall off their chairs when I try to say morphine and breathlessness, saying, are you trying to kill our patient? But please remember, enough research has been done for low dose use of morphine. They're extremely safe and effective when given in appropriate doses for patients with chronic breathlessness. The pathophysiology of morphine in breathlessness is very different from that in pain. In pain, we do give a high dose and then see to it that the patient is pain-free till we titrate. In breathlessness, we start low, go slow with laxatives, and give these patients 2.5 milligrams twice a day and slowly increase it weekly till the patient is comfortable. We rarely need to use about 25 to 30 milligrams. Next slide. So morphine is a wonder drug. It's a safe drug. It's effective. It has improved the quality of life of many of my patients, and actually, therefore, also the quantity of life of patients, because patients are more happier, they're more relaxed, and they're able to do small activities like going to the toilet on their own, eating with family, talking sentences fully on the phone. These are the challenges. These are the marathons for our patients, and making a small difference in their life is very, very satisfying. And at least they can live with dignity and respect towards end of life. So this is how we say that morphine is a wonder drug. Next slide. And what we actually do with morphine is, this is all the slides will be shared with you, but it helps to combine it with midazolam, either medium acting or long acting when there is an anxiety or panic attack. We continue all the other underlying medications like oxygen, non-invasive ventilation if needed for type 2 respiratory failure or congestive cardiac failure, bronchodilators, antibiotics, antifibrotics, all that is continued. Morphine only reduces the sensation of breathlessness. Next slide. It does not cause hypoxia, worsening and respiratory depression. None of my patients have died due to morphine, and it does not worsen the type 2 type 2 failure if used with BiPAP, because that's the treatment for type 2 respiratory failure. In patients, next slide, with terminal breathlessness, which can be seen in any patient, be it cancer, CKD, CCF, COPD, ILD, it's very, very important to converse with the family, that it can be very distressing for the patient and for the caregivers, and therefore we prepare a drip of morphine and midazolam. If the patient is agitated, we also add haloperidol to this 24-hour drip, and it is given extremely slowly. Intent is comfort. The side effect is, yes, death, but death when the patient is transition in peace, not struggling like a fish out of water. So very, very important to document this, to explain to this, and we do give patients at home, once we have all the necessary consents, once the families comfortable with the thought, the GP is educated, and this is started even at home. So it's quite commendable as how the relatives feel so reassured that they didn't watch their loved one suffer. Yes, they will lose their loved one, but with respect and dignity, and not a lot of suffering eased. And so palliative sedation or treatment for terminal breathlessness is a drip 24-hour subcutaneous infusion with morphine, midazolam, and sometimes haloperidol. Next slide. So this is what is palliative sedation. It's just a slide to recoup what I said. Next slide. Any questions on breathlessness? Any doubts? Any issues that you feel is impractical, difficult, scary, need
Madam,
to try?
what about
Yeah.
patients who are already on high dose of morphine?
Yeah. So those patients who are high dose on morphine, still we always start low, go slow. You start with 10 milligrams, keep the drip rate where it goes over 24 hours, slowly increase the drip rate. Because please remember, this patient will be sedated, will be unresponsive. So we don't want to give a whopping dose of morphine where we actually give the injection and it ends in the death of the patient. Yes, it will. The point is to explain that the condition is so critical and the patient can die anytime. But sometimes in the mind of caregivers, if you start a drip and the patient dies, injection ke wajah se hi ho gaya. So we need to keep reiterating it can happen anytime. I am giving the smallest dose possible. Even with this dose, it can happen. But most important is the patient will not register suffering. He will not be awake and aware of his distressing symptoms. And the point is, it is his current clinical situation is incompatible with life. Therefore, we are doing this to keep him comfortable. The intent is comfort. The intent is not to end life.
Madam, do we take an informed consent for this?
So in our practice, what we do very clearly, we say that I have understood the clinical condition of my husband, father, mother, whatever, in the language I understand. Currently his situation is very critical, and because he's not been able to maintain oxygen or his blood pressure because of all this, we give the consent to start. We give the consent to start this combination of morphine stroke midazolam, knowing fully well the patient will be unresponsive and it may result in death. And take the consent, time it, date it with all the family members who are part of the legal. So spouse, adult children, important in that order. Then comes siblings, and then comes anybody else. So first has to be spouse, legal heir, and adult children.
Ma'am, in relatively stable patients, morphine 2.5 mg should be started BD or?
So what we do, sometimes patients are very resistant. There's a lot of opioid phobia. In which case, what we say, start it as an SOS dose when you're very breathless. Convince yourself what difference it makes. Then you do 2.5 BD for a week. Then make it 8 hourly. Then make it 6 hourly. Then what we do is after 6 hourly, we say you take SOS doses in the middle. And then we don't need to give more than 25 milligrams in the day. And we use immediate release. But in Bombay, we get also only immediate release and vials for subcutaneous infusion. Any question, anything on the chat? I thought Sunil had put something on the chat. Nothing?
No. They were asking what are the other alternatives for.
Acha, you had put thiopental.
Yeah, thiopental.
Okay.
Any benzodiazepines, propofol,
Yeah.
etc.
Yeah. Okay. Good to go ahead or wait for some more questions?
No, please go ahead.
Okay. So we come to cough, which is another very distressing symptom. A protective reflex to help the airways clear foreign bodies, but when it's repeated, when it's persistent, it can be very distressing and cause a lot of side effects like hernias, syncope, fractures, etc. So it's important to, when it's distressing, especially in conditions like airway and interstitial lung diseases, and of course in cancer when there is a spread to the cancer. Next slide. So again, we need to realize that it is not just the lung that causes the cough. It could be gastric, it could be cardiac, drug-induced, treatment like radiation, it could be ENT, and sometimes even attention seeking like psychogenic cough. So we need to get the history well in order to find out where the cough is coming from. And sometimes simple things like early light dinner, a little bit of a 3-hour gap between dinner and bedtime, propped up position, a stroll before bed, that can actually alleviate some symptoms of cough. But if it's a distressing cough, like in terminal cancer or advanced COPD ILD, it needs treatment. Next slide. And often the non-pharmacological treatment remains the same. Like you ask the patient take deep breaths, particular positions. You ask the patient to, do lozenges, gargles, hot water, etc. But most important is to check whether they're taking inhalers correctly, see if they need gastric treatment for reflux, optimize their cardiac medications to decrease the preload. And also the other conditions we use first is, of course, we give local ones, like I said, lozenges, etc., cough suppressants. We give codeine syrup, again, not very commonly available. And we sometimes patients with breathlessness also, the ones who are on morphine, that also benefits the cough. And there is a very interesting observation of gabapentin, which is used in refractory cough. Next slide, please. So often gabapentin, when we use it in the night, we start with a night dose because it also induces sleep. So patient is comfortable during the night. And then we increase it to 300 milligrams 3 times a day. That can be given for intractable cough. And of course, you can give medications like baclofen for ACE-induced cough after stopping the ACE. So there are multiple things you can do. I think the most important thing is to listen to your patient and acknowledge the distress. That itself will make the patient comfortable, and then try these various things like syrup, then morphine, then gabapentin, etc., along with lifestyle changes to actually make a difference. Next is pleural effusion, again encountered very often, mostly malignant conditions as well as tuberculosis, but the malignant effusions are the ones which are difficult to treat. They can be recurrently filling, they can be distressing. All our patients who have pleural effusion, depending on the size of the pleural effusion and the prognosis of the patient. So the patient has a decent prognosis of more than 4 months, you can do a better interventional techniques like pigtailing. But if the patient's prognosis is very poor, then it's important to relieve his symptoms by one-time aspiration, and we then give the patient morphine. So what you need to understand is it all depends on the prognosis of the patient and the quantity of the fluid. So massive recurrent effusions, if it is patient is going to be alive for more than 4 weeks, we should put a pigtail. Next slide. So when it's small effusions, you observe. If the prognosis is less than 4 weeks, you aspirate one time. Recurrent pleural effusion with a decent prognosis, you put an indwelling catheter. So all these things are important: the stage, the prognosis, the functional capacity of the patient, and the response to drainage before you decide on how you're going to treat the patient. Next is hemoptysis. Again, can be scary and also life-threatening. And it's not that the patient dies because of the loss of blood, but in the lung, he can also die because of aspiration of his own blood, like drowning in his blood. And small things, see what happens with hemoptysis is you need to plan and tell the patient beforehand that this can happen, because very often we know it's close to an artery, it can erode into something. You need to prepare the families with dark towels, give them emergency contact numbers for hemoptysis, because hemoptysis cannot be managed at home because of the complex interventions that are used. Like, next slide. So we can use brachytherapy, we use laser, we use endobronchial laser, we use bronchial artery embolization, we can use radiofrequency ablation. So these things are not possible to do at home, but yet these are palliative measures to control the bleeding. So patients' family members need to be aware of where to go, whom to contact, which hospital will provide these things at 2 a.m. in the night. So they need to be given the numbers and forewarned. So it's important because it can be very scary. Even if you've prepared the patient and family, they need to really have the contacts of where to go. Next slide. And I think I will rush through these slides. So these are important things that I think you know how to manage it by using tranexamic acid. We give endobronchial also, we give injections also, and also we stop all the anti-bleeding, the blood thinners, and you need to rush the patient to hospital, especially if these interventions have to be done. The next few slides, actually, you can change it. Can you? It is about the pandemic. It's important. And I think in every talk of mine, I do definitely talk about the pandemic because it was a hard time for all of us. And of course, our patients and including the common man. And it actually brought into sharp focus about the need for palliative care. And I think if in India, people were trained in palliative care, a lot of things would have looked different in the pandemic because right from the time of triaging the patient, which patient goes to ICU, which patient goes on the ventilator, those things would have been streamlined, especially in a resource crunch country like ours. Secondly, optimum use of oxygen, very, very important. Very often oxygen is abused and everybody who is breathless gets oxygen. Please remember that one needs to give oxygen only if the saturation is below 88. Above that, it is anxiety, other things that are causing the patient to be breathless and not the hypoxemia. So please use oxygen rationally and educate your nurses also and check the oxygen saturation before you start, because unnecessary oxygen giving also damages the lung by the release of nascent free radicals. Also, like we saw in COVID, a lot of people died not getting oxygen because of overuse and abuse of oxygen. So if we really need to be prepared for a future pandemic by educating ourselves in palliative care, selection of patients in ICU, being there for our patients and each other, so much of compassion burnout for each other. So very, very important that pandemic got death and dying into sharp focus. We need to start talking about death and dying, prepare our patients because death is inevitable and a bad death is avoidable. So with that, I will end the presentation and we will go to the, we can stop sharing because this is all about COVID and palliative care. Now you can start the case or we can finish the discussion, whatever suits everybody.
Yeah, I think we will move on to patients.
Yeah, I'll just get some water for myself. 1 minute.
And then we will questions. Okay.
Yeah.
Okay. So today's patient story will be presented by Dr. Punita. Dr. Punita, please.
Hello. Good evening, one and all. Thank you, Rajam, for yet another wonderful class. It gave us a very a big bird's eye view of the entire palliative care. Now I would like to present a respiratory case. This patient is 45-year-old. She was diagnosed with right lung squamous cell carcinoma and with query metastasis and pleural effusion. At the time when she met us, she was still under evaluation. Primarily, the reason for consultation with palliative care was the progressive breathlessness. She was on BiPAP, but still she had pain and she was not at all sleeping. Like she had 1 week of sleeplessness and distress. That's why the pulmonologist has given a palliative care consultation. So she had shortness of breath for 4 days, which was worsening. It was progressive, NYHA grade 3. I was not sure of the MMRC grade, so I hadn't graded it. And she had cough with expectoration. She had some minimal hemoptysis. The family was very apprehensive about it more than the patient. Next slide. She had no history of fever, no loss of weight or loss of appetite. She was a normally built and normally nourished female. She had not slept since 1 week because of this intense pain and breathlessness. It was on a score of 7 to 8 by 10 on the anterior surface of her chest wall, anterior and posterior surface of her chest wall. She requested for symptom relief and some sleeping medicine when I met her for the first time. She was calling me aside to tell that I know they are talking about lot of tests and biopsy and reports has to come, but whatever be it, just treat my pain. I have not even slept for 1 week. And she had a positive history in the family. The mother-in-law who was staying with them was TB positive. and her samples were sent for AFB, which all finally came out to be negative. On examination, she is well built and nourished. She is conscious oriented. She could not lie flat on bed. She was sleeping in sitting position only. No pedal edema. She had some kind of raised no pedal edema, no raised JVP or ascites. So her saturation was 98. She was using on and off BiPAP because of breathlessness. Her BP was 110/70. Pulse rate was 94 and her respiratory rate was a bit higher on 30. She was having BiPAP especially on demand basis, mostly in the early morning times. Systemic evaluation, the air entry was equal bilaterally. On the right, posteriorly on the right side, there was little bit of reduced air entry. That was a site where they had done biopsy also. The other systems were normal. The treatments and treatment she had undergone so far and the investigations were like all her routine tests of complete blood count, renal functions and liver functions were done, which was found normal. Before admitting to our hospital, she had gone to another hospital where her pulmonology checkup was done. She was found with Klebsiella pneumoniae because of that lung signs. They had done a BAL and it had shown Klebsiella in the culture. They had started antibiotics for that and she had completed the course of antibiotic. And the CT chest showed 5 into 5, 4.3 centimeter thick walled cavitary lesion and no pleural effusion. Bronchial and peribronchial thickening were there. Air trapping was found, which was suggestive of hyperactive bronchi, and bilateral basal segment ground glass opacities were seen. She had undergone a PET CT also. That showed right lung mass abutting the pleura with satellite nodules in the lung and with collapse and meds to the paratracheal nodes and multiple thyroid nodules positive, which they had suggested FNAC for from the thyroid also. She was also has suggested sputum AFB, culture sensitivity, and PCR CBNAT, which all turned out to be negative later. She underwent a CT guided lung biopsy at our center, and histopathological examination showed squamous cell carcinoma, which was poorly differentiated. For which, like,
She was not a smoker, na?
no, ma'am, she was not a smoker, but
Passive smoking?
Ma'am?
Passive smoking?
Passive smoking is possible, and she is like she is the one who lives in like outside a stove also they use, and normal gas also they use. Passive
No, because squamous cell is very, mostly when non-smokers get cancer of the lung, it is adeno.
Okay.
Squamous cell, small cell is commonly seen in smokers. Of course, these days you cannot be, I mean, never is medicine is not black and white, but most commonly non-smokers get adeno. Squamous is the central tumor usually seen in smokers.
Okay. I couldn't get the pictures of this CT actually.
No, that's fine. But history of passive smoking therefore also becomes important.
Okay, ma'am, sure. So she was on tablet Dolo 650 3 times daily, and the pulmonologist himself had put the buprenorphine patch, transdermal patch, some 3 to 4 days before referring to me. Now he is a little bit counseled. Before and all, he was very much apprehensive to use morphine in his patients. But now I'm getting regular referrals from our pulmonologist. Thanks to you, ma'am.
No, not thanks to me. Thanks to all our collective efforts.
That's true, ma'am. Even I was very apprehensive to start morphine for the first patient, but once I saw the relief, saw them lying down and sleeping up from the sitting position, then I believed in it. And she was on tramadol 50 mg SOS and duolin nebulization 4th hourly. And
so buprenorphine and tramadol?
Yes, this was what they had prescribed, and syrup Lupitus TID. They give some thing to increase the appetite. for all these cancer patients, they give something, Lupitus, and then 5 days of augmentin was over. Oncology advice was taken, and they have planned for 6 cycles of chemo. This presentation I had sent a month ago to Shripriya, but now the patient came after 4 cycles of chemo. Today she has come back for this thing. Now she is doing much better. Today I had reduced her morphine dose.
Very good.
So psychosocial aspects, ma'am, are you able to see the slide? The next.
Yeah.
Yeah. So this lady, she is very oriented and composed middle-aged lady. She is suspecting some bad diagnosis like a bad TB or tumor, because everyone around her is talking about that something is wrong, some report has to come and all that. And she has been sent from her village to Trichy to Coimbatore. So she senses that something is wrong with her. But she is telling whatever is wrong, but my symptom at least should get controlled, that I should not be a burden to my family. The family, the husband is having some kind of visual impairment, but he is able to make some money for the family. He sounds concerned about the wife. Probably he is a smoker, but I have not really elicited the history, but I'll have to take. And this lady has a brother who is very supportive, who stays with the patient most of the times. Whenever we are going for a rounds, this brother will be very concerned, standing with them. Will you need anything else, doctor? Like that. She has 3 children, all are grown up. There are 2 daughters. Both daughters have got married. They are not staying in the same village, but somewhere else, but they cannot come regularly and take care of her. Maybe they can come in turns. When she comes to the hospital, they are all coming and staying with this patient. They are trying to be helpful, but they are physically not very nearby. The son is 18 years old, and he is working in some local shop, and that is a socio-economical status. They are agricultural daily wage workers only, but still, because of the good family support, they are thinking like every month, if they are able to, like for first 2-3 cycles, if they can pull up some money of 20 to 25,000, definitely they thought they can finish the chemotherapy. So they are very compliant.
They can't get anything in Trichy.
They have not explored it, I think, ma'am.
No, so we should also help them explore, because that also is a tiring thing. Plus, they lose daily wages coming to Coimbatore. So many things. So it's not like you're going to say go away to Trichy, but we should find some local support for them.
Okay.
Think about it.
Yeah.
So much time and effort will be saved for them. I'm sure Pallium India can help you find some center in Trichy.
Okay, ma'am. So she is currently in the 4th cycle of her chemo. Like weekly once she has been advised. And this was the initial medication I started her on, seeing the 7 to 8 score, numerical rating score. I started her on morphine SR, 10 mg TID, and more tablet morphine plain 10 mg SOS for breakthrough pain. This thing she used during admission. She was given SOS doses initially, but now after going home, she is only on that SR. She never took a single SOS tablet. All those plain tablets are with it.
So you get SR in Coimbatore?
Yes, ma'am.
Okay. We don't get here.
Ma'am, I have a doubt. Like if there is SR availability, can I even make it SR? Now I want to down titrate the dose.
Yeah, you can make it immediate release.
BD, or can I make it SR 10 mg BD?
Yeah, of course.
Okay. So I was thinking between 5 mg SR TID or 10 mg BD, which will work out.
No, 10 mg BD is quoted in the Western literature.
Okay. So I started her on bisacodyl 10 mg HS. She is doing good with that, but still now also a patient is complaining of constipation on and off. So I have told whenever for 2 to 3 continuous days she has not passed stools, then on the 3rd day they can give 2 HS.
Yeah, but you also check the diet.
Oh, okay.
Because only giving increasing laxatives and she's not eating, or she's eating things like, sometimes patients who eat apples get constipated, or they don't eat any roughage.
Okay.
So just check the diet. And typically in the South, raw salads is not a concept.
Yeah.
In the South, we very rarely eat raw salads. Our salads stopped with either the raita, that is the pachadi, tair pachadi, or it is the sundal. We
Yeah.
never use the salad form like the North eats and the West eats. We don't have. So
Okay.
see if they eat, for
Diet.
banana every day, papaya, those kind of fruits at least.
Okay.
Hmm?
Okay, ma'am. And this paracetamol TID, now they have stopped. This was given only in the hospital time. And ondansetron 4 mg 1 S was given. But now today's visit, what they're telling us, after this third cycle of chemo, she's not eating anything. This she just told today that she's not, the moment she thinks of food, she's feeling nauseated. This time, actually, this visit, she told, pain is not my problem, doctor. I am having vomiting. So this case history notes I had put like last month when I saw her for the first time. So exacerbation of breathlessness was there, and there was drop in SpO2, as you told, like it was like somewhere between 85 and 90. And we generally don't keep the patients in ward if it's less than 90. We shift to ICU. But for this patient, we could, because she was not affordable, we got a BiPAP machine, kept it in the ward, in the TB and chest ward, and managed with, after starting morphine, she improved in saturations also because the pain went down, and she doesn't keep her body very stiff and all. And
Also, morphine improves the tidal volume because morphine acts as an anxiolytic.
Okay.
And it therefore makes the respiratory rate slower, and therefore the depth of respiration improves. So very often patient saturation improves.
Okay.
Because anxiety becomes less, tidal breathing improves, respiratory rate decreases, work of breathing decreases. So they don't spend energy doing, they have less. So therefore they breathe better and deeper.
Can we even give IV morphine trial to decide the dose for such patients?
No, we do IV morphine trial for pain.
Not for breathlessness and
No.
Respiratory patients.
There is no documented evidence.
Okay, okay. So for this patient, I had started oral only, and she responded well within like 6 hours and all. There was response. The very next day, the BiPAP need was reduced. The second day, BiPAP was taken out totally. She could get discharged on the fourth or fifth day. Then the main concerns in this patient was like at that point of the first admission, breathlessness and its progression, which really brought them to this hospital. She had orthopnea. She has not even slept lying down position, and pain in her anterior chest wall, right hemithorax on deep breathing and coughing, sleeplessness. And she was at that time, she was worried about the cost of chemotherapy, which now they have somehow worked out, and they have finished 4 cycles as of today.
So is she sleeping better with the morphine and with all these interventions?
Yes, ma'am, she is sleeping. Now, currently, her main problem is after the third cycle of chemo. It's
Food.
Yeah, nausea. Constipation again.
She knows the realistic truth of her condition?
No, ma'am, today also I have not told anything.
And reason being?
Ma'am, to the husband, like I could speak with the husband. Husband is telling, let the chemo finish. Let us see if she improves or so. Don't tell in this setting.
So this is collusion, right?
Yeah.
You need to work towards because it's not fair to deny to the patient the basic right of medical ethics. We can't be party to collusion.
Okay.
Yes, we acknowledge that yes, it is difficult, but we are not going to abandon the patient. Na? We are going to see the patient. We are going to support the patient.
Yeah.
So we have to find out why don't you want to tell the patient?
Ma'am, one more inhibition I have is pulmonologist is a primary consultant, and should I?
So pick up the phone and tell the pulmonologist. Why haven't you told the patient?
Okay.
Nowadays, I do that. It is not your responsibility.
Okay.
So talk to the pulmonologist. I'm concerned. The patient doesn't know the truth. Somewhere somebody will look at her paper or his paper, and she will get to know from another resource, which is worse, which is that we are betraying the patient.
Yeah.
Isn't it?
Because every time we send her for chemotherapy, that time it's all written in Tamil only, ma'am. She can easily understand.
Exactly.
By now she would have known, but we
And which is not the right way to know, no?
yeah, that's true.
Somebody's asked a question about alternatives to morphine. Sunil is the best person to answer that. I think methadone, I have never used for breathlessness. Patches may be used, but again, the release is slow and it's expensive and it's a tropical country. We don't. Sunil, do you want to take that question?
And buprenorphine, what about buprenorphine, ma'am?
So it's a patch, now. We don't advise patches. I mean, I don't. It's more expensive. It's also tropical country, so the sweat, everybody cannot sit in AC.
Yeah.
Plus, suppose the patient is breathless on the patch, you don't know how much is the circulating morphine. Sunil has replied saying fentanyl and patch. Yeah, those are the options. I agree.
Okay. Next slide.
Is that answer your question, Parul?
I wanted to know if there are no opioids available to us.
That's what he said, na? Fentanyl patch. The pharmacology, I mean, sorry, the pharma company see to that fentanyl patches in gaon mein milta hai.
Okay.
And the other one he said also was fentanyl drip, which you can give in the hospital.
Okay.
Okay. Thank you, ma'am.
Tramadol, any experience, ma'am?
No.
Okay. And I also wanted to know about oxygen in such cases, like home oxygen in such cases. When we go back, because she has a bit, we don't know about the prognosis of this patient still, but she's been on chemotherapy and they are very keen to complete the chemotherapy also. So BiPAP or
see, oxygen should be used only if the saturation is below 88 or the saturation falls. Patient desaturates on walking. That means patient needs oxygen on activities.
Okay.
Otherwise, you need to address anxiety, you need to address pain, you need to address breathlessness, you need to address everything else, and then maybe the patient will be much more comfortable. And breathlessness is not just because of respiratory, no? So if you address all that and she doesn't desaturate on oxygen and oxygen saturation remains well, there is no need to provide them with oxygen.
Okay.
And see, oxygen usually falls either very advanced cases of cancer, or if the patient has overlying COPD, interstitial lung, cancer. Only cancer tumor in one place is not going to make the oxygen level fall. Anatomically, people live with one lung, right?
Yeah.
So if only the airways are affected or the advanced cancer because of deconditioning, anorexic cachexia syndrome, multiple other things, then they get breathless.
Okay.
Only one patch, young lady, she's only 45. She's 10 years younger to me. She would be well preserved. It's unlikely that they will have breathlessness due to the cancer if they're not late stages.
When patients have the rib erosion, I have another patient, like she has 3 ribs affected and some vertebral lesions also. A similar lady, like 53-year-old lady. Which pain like that, only morphine will be good, or should I think?
No. In fact, bone pain, morphine doesn't actually always work well. Then you need to give other medications. That's a full session on bone metastasis. That pain management, sometimes morphine doesn't do a good job. We need to give other medications to release the pain. Sometimes radiotherapy also helps.
Okay.
So radiotherapy, bisphosphonates, and you do the pain ladder, but some more, quite a few times, morphine doesn't help in bone mets. Correct, Sunil?
And this patient for radiotherapy.
Hello, ma'am.
Yeah.
This is Priya once again.
Yes.
As far as I think this was a discussion about, sorry to interrupt, because I was trying to tell when you're giving morphine for breathlessness, it basically acts because it decreases the pulmonary capillary pressure, the afterload and the preload, which I don't think is there with the other drugs. So
the other thing it does is decrease, it basically does suppress the respiratory center, right?
No,
So
that is common factor with all the opioids.
Yeah.
But the reason why it helps in maybe a pulmonary edema or this type of breathlessness is because it also reduces the pulmonary capillary pressure, reduces some amount of edema, and that's how it helps. So I don't think the other opioids function in the same way. They don't have, they only
No.
directly cause
The
respiratory
point what
center
we're also
depression.
trying to, no. See, in a patient with COPD or ILD, there is no pulmonary edema. In a patient of advanced COPD and ILD, there is no pulmonary. I mean, even they can have even a normal 2D echo. There is no pulmonary edema. So the mechanism of action of morphine, I'll share the paper with Pallium,
Yes.
is multiple things. It decreases the respiratory center,
Yes.
respiratory rate decreases,
Mm.
work of breathing decreases, it also acts as an anxiolytic, the tidal volume improves, the sensation of breathlessness reduces.
Yeah,
Nothing happens anatomically.
reduces.
The sensation rate. So the patient just feels less breathless. So feels
there
more
is a-
confident to do other things. Yeah, Sunil.
So there is a systematic review which says breathlessness, refractory breathlessness due to any cause, opioids will be useful.
Correct.
So
All
it is
opioids.
not, all opioids, but that may not be true. But it should be. But the most of the research was on morphine and some other opioids like fentanyl or
But
oxycodone.
abroad, they do use other opioids, right, Sunil? They do use hydromorphine and
Yeah.
They do use
They
all
use.
that.
Yeah.
We not
So that-
available for us. So that's a different thing.
Ma'am, I have.
So breathlessness is primarily a sensation. So when you feel, it's a sensation. So what opioids do, it reduces the sensation. And as Dr. Rajam told, there are many other mechanisms of action by which opioids reduces the breathlessness.
Ma'am, I have
Correct.
another question. Like patients with ICD chronically, when they have some bout of increased pain, does giving some bupivacaine or lignocaine through the tube helps? Any experience on that in that?
No. You give locally there. Don't put anything in the pleura.
Okay.
You should put locally, you should give painkillers and all that. Don't insert anything in the pleura because pleura is, you have to be very sterile.
Okay. Because sometimes when we give this intrapleural, like pleural blocks and all, we infiltrate some local anesthetics and all for few patients undergoing thoracic.
That is, no. See, that is different while doing the procedure, but as a regular pain control measure, avoidable.
Okay.
Okay. And so you want to discuss, what are your discussion points?
Pleural effusions, they come again and again with the pleural effusions.
Yeah, so you should not scan frequently. Again, you should do symptom. If the patient is breathless with or finds it difficult with the pleural effusion, to quantify, you can do a sonography. That also costs money. But most important, the symptoms should dictate and the prognosis should dictate. And if there is a prognosis is good, you should put a pigtail. The pulmonologist should be able to do that.
Okay. Ma'am.
Yes.
This patient, buprenorphine, did it really help her or not? I don't know, because she was very unhappy with the patch. That's why I had to take it out and start on morphine.
The patch could be unhappiness because of money.
Okay.
Patch is expensive.
The other question is already answered. Morphine, like how well is it tolerated? Like you told us from like 2.5, say we can start, and that is answered. So for pain relief, this dose is good to start with, no, ma'am? Yes,
Not pain, breathlessness relief.
Breathlessness relief, 2.5 is good to start with.
Yeah, correct.
And morphine histamine release is it a concern in respiratory patients? That's what I used to think.
No.
Okay, so this patient's situation improved with morphine. That by now I have seen it. And nebulization and MDA inhalers.
Do not use nebulization. This is where I feel that lung function is very poorly underutilized. Nebulization and inhalers are for airway diseases. Does she have an underlying airway disease? Then don't waste her money.
Because right and left we write for everyone, and they will be really running around to get these inhalers.
You are abusing inhalers without lung function. Is there a family history of asthma? Is there
No.
family history with recurrent episodes, dust, smoke, change? Is she a smoker? Is she passive smoking? See her lung functions.
So
Don't unnecessarily prescribe inhalers. It is really over abused. And with this, I would like to say that we are thinking of having another round of respiratory medicine for palliative care physician sessions sometime this year with Pallium, where we will give you the pathophysiology of COPD, ILD, BiPAP, oxygen therapy, etc. So don't use everything in everybody. It doesn't make sense. You're wasting the patient's money because inhalers are not cheap. They do not make a difference in patients with interstitial lung disease.
Okay.
So use your PFT. Na? You have PFT machines na, in your hospitals.
Yeah, we have, ma'am.
Tell the pulmonologist, ask the pulmonologist, does this have a patient have an airway disease? Is it asthma? Is it COPD? What is it?
For this patient, that acebrophilin bronchodilator, I don't really know if it's helping her, but she's been continuing it for quite some time.
I don't think I need a PFT to see what is actually helping her.
We have not repeated PFT on her, ma'am.
No, what is the initial PFT?
Initial PFT was it was more than 1.8 FU1.
I need to know the reversibility. Why do you give inhalers? For bronchodilation. How do you know the bronchodilators are helping when there is a reversibility? What is reversibility? Do a pre and post bronchodilator reversibility to see if the amount of FEV1 has increased by 20%. If not, there is no need to give the inhalers.
Okay. And
doing one PFT doesn't make a difference.
Okay. Then early morning, she used to ask for Nebu before. Now we have tapered, and what SpO2 is acceptable, that I've got it answered. Like,
yeah,
I can wait for till 85. We can wait, no, ma'am.
88.
88. Okay. And then will incentive spirometer help in such a scenario?
Again, the point is incentive spirometers improve the lung stamina, and you basically you recruit airways which are collapsed.
Okay.
When there isn't an airway disease, when there's no surgery done, I don't think it's all a waste of time and effort. Then in this case, simple patient needs to do aerobic exercises. Hand, leg, walk.
Incentive spiro, will it worsen her? Like maybe will she get hemoptysis or
that cavitatory lesion can rupture also with the poo that they do.
Okay.
Don't do, these things are, I think, it's like some things get caught on as a fad.
Okay.
There's no scientific logic to it. It's not a blanket for all,
Okay.
So avoid it. It has to be individualized, the physiotherapy you use.
Okay. So can massive hemoptysis prevention be done? Like, should we counsel her now only?
No, you should prepare her that it can happen.
Okay.
And like I said, you should give all the contacts where interventions can happen.
Because she has a big cavity.
Yeah. And it can erode into any artery.
Okay. So it is now only we should start sensitizing them about it.
Yes.
Family?
It may happen. It's great if it doesn't happen.
Okay. Okay. Yeah. Yeah, that's it, ma'am.
Any other questions, thoughts, anecdotes?
Please unshare the screen clip.
Dr. Punita, what is this second point, use of POCUS? What is POC?
Ma'am, that is point of care ultrasound. Nowadays, like every specialty person is getting taking the ultrasound probe in hand. A urologist will see the bladder and then put SPC. Gynecologist will see the uterus and put the probe. They don't puncture, So anesthetist use. So palliative people also, emergency physician use. Palliative medicine people are also using it. Like we can quantify the effusion. But it needs.
So instead of sending to radiology department,
Madam?
just as a scan to get an idea.
Yeah.
What is the cost of a fentanyl patch? Because said fentanyl patch or morphine as an
from my memory,
it varies between 250 rupees to 400, 500 rupees. So 12.5 microgram patch is the lowest patch that you can get, which may cost between 250 to 350 rupees.
to be changed every 3 days.
Yes, ma'am.
And
72
a
hours.
morphine strip of 10 milligrams is 30 rupees.
Okay.
We had, I mean, during the course, it was what I understood was that morphine is usual dose is 5 to 10 mg Q4 hourly. So here it was given as 10 mg TDS. So does is it the optimal dose or should it have been Q4 hourly?
No. So that's where we were coming to. The dose required to alleviate breathlessness is way lower than pain. In pain, you're taught there is no ceiling dose. In morphine for breathlessness, if it is going beyond 25, you have to start thinking of other reasons the patient is breathless. We do not go about 25. We always start low, go slow. And 25, we start with 2.5, 12 hourly. Then make it 8 hourly, then 6 hourly with SOS doses. Very rarely we need to give. So if the patient actually requires frequent morphine, that means he's probably likely to be at end of life. Otherwise, this patient will not be so desperate or there's something else contributing. So we never need to use more than 30 milligrams morphine ever in breathlessness.
And this one is sustained release.
Yeah, this is sustained release, correct.
So TID can be okay, no, ma'am? Should be okay.
Yeah, it's 30, na?
No, her doubt was that only.
No, her doubt was, you see, any amount of morphine you give,
Mhm.
immediate release, it is removed from the system in 4 hours. She's correct. That's why in pain, we give by the clock, by the dose, by the everything. But in breathlessness, it is definitely not as much as what you need in pain. And you need much lower doses to alleviate breathlessness. And unfortunately, yet it is not prescribed.
Okay.
Sustained release half-life is, I mean, it's eliminated. What it's given BD or TDS should be given in if it's an SR.
No, Sunil, we can give sustained release half-life is how much even I am kind of not sure.
So sustained release acts for 12 hours. So you need to give only BD.
So you can give
there are
15
some
BD.
situations in which you can give TID. It is okay, but usually it is 12 hourly.
So could this patient have got 15 BD?
But if you want to give, I think 10. I don't know whether 5 milligram SR is available. Only 10, 20, and 30 is available. Not 5 milligram, 15.
It is a small tablet to break also, sir. 10 mg only.
No. If you break SR, the property will be lost. You should not break SR tablets.
Okay.
Sir, one doubt, because the sustained release is given only after stabilizing with the IR tablet of morphine. Straight away, can we give sustained release tablets?
So in the West, they do give. The West, they start with SR. They give 10 milligrams SR BD.
BD. So
that's how they start.
So this is not like pain management. In pain management, usually we don't know how much dose would the patient require. But as Dr. Rajam told, in breathlessness, usually the dose of morphine required would be in the range of 20 to 30 milligram. So starting with the 10 milligram BD, SR morphine should be okay.
And we could have added midazolam also. That is also effective in breathlessness, no, sir?
If we feel anxiety is a big component.
Okay, terminal case. Terminal
so try counseling, try other things, and then you can add. Definitely you can add.
Thank you,
ma'am.
It is not the first line drug. Benzodiazepines are not the first line drug to treat breathlessness. It is only the second line.
Okay, sir. Thank you.
If I have to start bisphosphonates for somebody with vertebral meds, what all precautions should I take?
See, if it's a palliative treatment, pain is the most important endpoint.
Okay.
So you should try radiotherapy, you should try analgesics before, and then maintain the thing with bisphosphonates. Pain control is your endpoint.
Okay. This patient is not affordable for radiotherapy.
No, government hospitals don't have radiotherapy.
Okay.
For such palliative patient, you can give single fraction also.
Yeah,
If the
correct.
if the end of life care patient is there, you no need to go for 5 or 10. Single fraction is suffix.
Oh,
Correct. But I don't know whether single fraction also is expensive in a private, but government is also always there. Of
okay.
course, there's a long line and all of that will come.
Okay. With single fraction, will pain come down, sir?
Yes, it does. It does. And especially end of life, we don't know how long the patient is going to be there. So,
Yeah.
but even that is important to be comfortable, right?
Okay. Ma'am,
So just because patient is going to die tomorrow doesn't mean we let them suffer.
and sending them home with the ICD, what all should we?
Nothing. Absolutely safe. When we put pigtail and we attach it to your Eurosac bag. Have you overturned a Eurosac bag and seen?
Yeah.
Nothing goes into the catheter. So it's a one-way valve, Heimlich's valve. They can happily be tied to their petticoat, tied to their pajama. They can walk around. Nobody needs to know.
Okay. Okay.
It's a very good portable way to drain the fluid.
Okay.
Ma'am, I have a question.
Yeah.
Do you also see the patients of chronic lungs GVHD or the bronchiolitis obliterans in your practice?
Yeah.
Okay, so what helps them maximum for breathlessness?
Morphine helps if everything else has been tried. So
Okay.
boop, cop, everything we use, especially effectively they become airway disease, small airway disease. So if it is a what do you say, breathlessness which is or at rest or an advanced disease, patient is on optimum medication, still patient is not settling down, then you should use this for comfort. It should be used as a last resort when you've tried everything and the patient is still uncomfortable, including counseling, including psychotherapy, what is wrong, explore the fears, because all this can contribute to breathlessness. See, very often as a chest specialist or an MBBS doctor, we want to treat things, we never go beyond what we see. Okay, if not this, then this, then this. We never explore the mind. Because that is when it is a waste of our time. Now he's going to open and start complaining. So I'm not telling you to do it also. Get a counselor on board or refer him to a counselor. Say it'll help you to talk to this person.
So, I mean, this is a 35-year patient who has a chronic lungs GVHD and FEV1 was roughly around 50%. And on rest, he is fine, not totally comfortable, but still okay. But even slight like 10 to 15 minutes walk causes him to like rest for at least 5 minutes, 10 minutes.
No, what's the oxygen? 6-minute walk test.
6-minute walk test is fine. Like at rest, oxygen is around 93, 94. And even after 6 minutes walk, it stays 94 or sometimes even goes 95 also.
So
But,
that means it is not something, it is a normal response.
right.
So explore his thinking, explore if his life has changed. And in a 35-year-old, what we forget, Dr. Nikhil, is to explore other issues like sexuality. What if he has a partner? You're saying 10-15 minute walk, he's getting breathless. So obviously he cannot maintain any intimate relationships. We need to start getting comfortable talking to patients about it because it is life changing for them.
Right.
So all this can contribute to him becoming attention seeking.
Right.
Somebody is going to be there if I pretend to be breathless or I pretend to be helpless. But there might be so many other things that must be going on in his head.
Thank you.
That Blue Maple report you'll share with us, ma'am.
Yeah. Pallium also has. Google Baba also has.
Okay.
But should we not explore the other diseases like cardiac illness?
Of course. Always. Everything has to be explored. Cardiac, which is what I said. You have to find out everything. So if you should do an echo. You should find out smoking status. You should find out. Yeah. Everything needs to be
He
explored.
was just a week back, even going to a bath, his heart rate was going around 140, 145. So echo was done, it came out normal.
Yeah. But see, when the heart rate goes up with minimal exercise, it also could be deconditioned.
Right.
It is not always the heart. So today, if I take bed rest for 1 month and walk on a treadmill on the second month, my heart rate also will go up in the second minute to 100.
Right.
It is deconditioning. So it's not always the lung, the heart. Also deconditioning contributes to breathlessness. So what physio is he doing? All counseling, so many things. You have to look for all organs. And obviously exercise is as important as inhalers and medicines.
And in such cases, does incentive spirometry helps in your experience?
If you have documented an airway disease and you have started the physiotherapist starting to do all the muscle endurance, aerobic exercise, then you can use it to improve lung capacity. But apna simple pranayam can also do that.
Okay.
Why to spend that 300 rupees buying those balls and they get stressed with increasing the resistance and getting those balls high? Pranayam karo roj, walking karo, some form of physical exercise. Very, very important. And I think it also goes to all of us. We are so busy that we also don't have time to remove that half an hour every day. As a part of life, way of life.
Right.
Thank you, ma'am.
Anything else? Anybody else has a comment? I see some very senior doctors also. I'm sure they have way more experience than I do.
Okay. So
over to you.
What
Yeah.
about pulmonary hypertension, madam?
Pulmonary hypertension is very difficult to A, diagnose and B, treat. There are lots of newer medications available. Again, primary pulmonary hypertension, secondary pulmonary hypertension needs to be distinguished. Secondary hypertension is because of all the underlying lung conditions like COPD, ILD. So if you control that, you can control the secondary pH. But primary pulmonary hypertension unfortunately comes in younger patients. And these days there are a lot of medical interventions, stroke, surgical interventions that can be done. So young patients, we give 5 to 10 nail. And only when it becomes impossible to treat that patient, we actually get into palliative.
Ma'am, I have one more doubt. I have
Yeah.
an MDR TB patient who denied treatment. And he wanted to get discharged also. He was diagnosed to have myelodysplasia. So if isolation is ensured, we can discharge him to home for end of.
You have to first notify.
It was notified.
Second thing, he has to then in public places wear a mask.
Okay, ma'am.
And
he was almost bedridden.
Oh, then he still should wear a mask at home.
Okay.
And others around him, the caregivers, etc., also need to be, careful.
Okay.
Because they will then get infected with MDR strain.
Okay. So
and obviously he should be kept comfortable. That is a birthright of every human.
Okay. So
but in this case, he's a potential community hazard.
Okay. We almost like literally put Riles tube for him and tried giving the drug. But he just denied taking any TB treatment.
No. So the point is such patients, the air ventilation, rotation, all that needs to be ensured, which cannot happen in a house. So it has to be well ventilated house and he doesn't share the room with anybody. But in India, that also is not easy. You can have family of 10. Where will all of them go?
So the son was a physiotherapist who was working abroad. So he was very aware. So, but the patient was not willing to wear a mask at home. So the attenders were wearing, like the family people were okay to wear a mask.
But well ventilated room, no AC, windows open, all that has to, no children, no diabetics around him, because they're all immune suppressed.
Yeah, the wife was 72-year-old. They were like very much, the pulmonologist here was very apprehensive to keep him like this because he denied treatment. So they wanted to go against medical advice to home. Because if he wanted to stay at hospital, they wanted to give him a TB treatment. He was having myelodysplasia and he was on thalidomide.
Oh, see, the only difference between this and chemotherapy for cancer is that if a patient denies cancer chemotherapy, it only harms him. But if a patient denies AKT chemotherapy, it harms a lot of people.
Yeah.
So socially irresponsible it is.
Okay.
And that is the word I would use to tell the patient that, it's like how when you're driving, you curse the people, saying, other people who drive badly, you get affected. For other people's fault, you're affected.
Okay.
Similarly, this is for somebody else's stupidity, everybody else is suffering. So counseling is very important. There's some particular reason why he has, doesn't want to take TB treatment. Maybe it's the side effects he faces. So somewhere the pulmonologist has a much bigger role than DAMA. DAMA, according to me, should be scrapped from every hospital. It is a height of suffering for patients and caregivers.
This
That
patient-
option shouldn't be there only.
For this patient also, I had given buprenorphine patch only, like he had some amount of breathlessness. So we try, once he was little drowsy and all, then I put him on diazepam in the night and buprenorphine patch, and then gave a mask. After going home, it seems he accepted the mask. Here he never was willing to put the mask because of
No, he needs to accept treatment. And somewhere I feel responsible as a pulmonologist because MDR TB is created by us.
Okay, ma'am.
A lot of it we are responsible.
Okay.
So I will have to go that extra mile to convince the patient.
Okay. Okay.
Okay, I think we will wind up the session now. So thank you, Dr. Rajam.
Thank you, Sunil, for the
for
opportunity.
the wonderful
Thank you.
session. And thank you, Dr. Panita, for bringing out a lot of questions for discussion. And thank you all for an active discussion on this particular topic. Thank you.
Thank you. And
Shreya.
sorry again for the delayed start. I have delayed everybody's dinner.
No problem, ma'am.
Okay, keep in touch. And I'm not sure if this batch is aware of the IAPCON or it's too late, but we are having a respiratory palliative track day on the 11th of February, which is this Saturday in Bangalore at NIMHANS.
Okay, sure.
And watch this space for respiratory medicine for palliative care physicians sometime, God willing, this year.
Okay.
Okay, take care, stay safe. Thank you all for joining.
Thank you, Dr. Rajam.
Thank
In
you,
common
ma'am.
man's words, another breathtaking session on breathlessness. Thank you so
Thank you.
much. Your sessions
Thank
are
you.
always an absolute guarantee. So no exception this time also. And further to Dr. Rajam's this information on, I think, essentials of palliative medicine for pulmonologists, I believe the tentative date has been come to 13th of April, if I suppose, Dr. Rajam. I believe you
No,
have.
we haven't finalized yet, so
Okay.
I don't want to. I mean,
Okay.
we definitely want to do it as early as possible, but we will let you know. You're always there to tell all these interested people.
Sure. So please keep checking the WhatsApp group. The communications will be provided in the group as and when new programs get launched. And we do have a pain management program for oncologists, which has been announced starting from 5th April. So I'll be posting the details in the group maybe tomorrow. So thank you everyone for joining in, and thank you for staying back. As Dr. Rajam said, please go straight and have your dinners. I
Yes.
hope.
Have a good evening.
Yeah.
Bye.
Thank you. So this is Sripriya along with Dr. Rajam Iyer and Dr. Sunil Kumar signing off from the Tips Echo Hub. See you after 1 week with another interesting topic and yet another eminent faculty. Till then, everyone, stay safe, be happy. Take care. Bye-bye.